Thanks very much. It's a pleasure to join you. I wish I can join in person. I hope you can hear me okay. This is a Zoom presentation brought to you by United Airlines that unfortunately canceled my flight overnight from Toronto. But nevertheless, it's a pleasure to join you. Thank you so much for having me, and to Heather and her team for organizing this last-minute Zoom presentation. So my name is Lipsman. I'm a neurosurgeon at Sunnybrook at the University of Toronto, where I have the great privilege of working alongside some terrific engineers and others on focused ultrasound, which I'll talk about for the next 20, 25 minutes. This is an emerging tool that we're using, which I think is really apt for this conference and for today, as we talk about sort of what the future of neurosurgery will look like, and as we talk about less and less, and in this case, completely non-invasive, but less invasive approaches for challenging brain pathology. I often begin with this slide, which is the first page of a paper from 1954, to illustrate a few points about where we are, where we've been, and where we're going. The first point is that using ultrasound, of course, as neurosurgeons, we use it all the time. And the idea of using ultrasound energy or sound energy or acoustic energy to influence the brain is not new. We've been doing this now for several decades. And the idea of using focused sonication or acoustic energy in the brain has been around now for 70 years. Now, of course, we don't use terms like lobotomy anymore, but at the time, we were looking for ways to intervene in critical limbic circuitry to treat really challenging conditions, including mood and anxiety disorders. But that really underscores the fact that the motivation has always been the clinical need. And the clinical need is always driven by how can we intervene in the brain in as safe an approach as possible, but nevertheless having no sacrificing clinical efficacy. How can we balance safety with efficacy? So when we talk about ultrasound, we've come a very long way. So initially, single ultrasound transducers were used. Now we're at over 1,000 transducers. And what we needed to overcome in the field is really what's called the bone problem. So the bone, as we'll see, the skull, of course, attenuates more than 99% of ultrasound energy, as anybody that's tried to use ultrasound across the skull knows very well. The issue is once you get past the skull with ultrasound energy, you need to refocus that energy in a very specific way. So that's where the bone problem really comes in, and we'll talk about how that's been overcome. And really what the goal is this, which is illustrated back in the 50s, and we can do it much better today, but ultimately it's a lesion in the brain, or it's access to subcortical regions of the brain in a way that's safe and that preserves and respects surrounding tissue, specifically cortical tissue around it. So initially what started as 4 transducers in the lab of the Fry brothers, who were physicists who were well ahead of their time in the 50s and 60s. And here we are today, and there are different companies and different manufacturers out there that are really spearheading focused ultrasound. So whether we're talking about implanted transducers that are put in the skull, whether it's navigation-guided acoustic energy, or whether it's a system that we use in Toronto, which is the Exablate. There's a helmet phased array technology that contains over 1,000 ultrasound transducers with real-time image guidance. All of these technologies are really aiming to do the same thing, which is focus energy onto discrete regions of the brain. And at the point where ultrasound energy interacts with the brain is where a lot of the biologic effects happen. So we know that FUS therapeutics, focused ultrasound therapeutics, is rapidly expanding, and a lot of this has been driven by clinical brain applications. When we looked at over the last few years how the field is changing, the red line here is publications per year specifically dealing with focused ultrasound in the brain, and you can see the field is exponentially rising, and a lot of it being driven by human work, specifically in pain and in movement disorders, as I'll show you. So how does ultrasound interact with the brain? There are different ways. At last count, there are 14 or 15 different mechanisms that ultrasound can really interact with the brain at that intersection of acoustic energy and brain tissue. The 2 that I'll talk about this afternoon are high and low frequency. So high frequency, also known as HIFU. This uses high amplitudes, high power energy to generate a discrete lesion in the brain. Very similar to radiofrequency, very similar to LIT. It's thermocoagulative necrosis at a focal point where the ultrasound waves intersect. Low frequency, also known as low-FU, is very different. It uses low energy, low frequency ultrasound, And here the idea is transient permeabilization of the blood-brain barrier. And there's been hundreds of publications so far in a range of animal models showing that you can use LoFu in a very precise way to aid in the delivery of myriad therapeutics to the brain. So whether it's antibodies, genes, cells, nanoparticles, chemo, this may be a way to transiently overcome the blood-brain barrier and allow you to deliver therapies to the brain. There are other mechanisms, though. So people, including our group, are looking at neuromodulation strategies, histotripsy, which is another form of ablation, targeted on caging of nanodroplets, which contain chemotherapy and other drugs, as well as radiosensitization and hyperthermia strategies, especially for oncologic applications. All of these, again, are where the ultrasound waves ultimately intersect with the brain. So when we talk about future of neurosurgery in the context of ultrasound, as I've often asked, I think you can really summarize it in three answers. So what we're going to see over the next few years are expanding indications, the enhanced delivery of therapeutics to, again, a whole host of different indications, and a much more personalized approach to how we not only deliver care, but understand a lot of the diseases that we're treating. So the body uses of MR-guided focused ultrasound, those are quite established. So we've been using this for several decades, for several years. We've been using focused ultrasound to treat fibroids, prostate cancer, bone mets, and breast cancer, et cetera. But only in the last 20 years or so has the skull problem been overcome. So again, you'll recall that the skull will attenuate and absorb the vast majority of ultrasound energy. It'll diffract it, and very difficult to visualize it after the energy transgresses the skull. And only recently have we managed to overcome that. So what we needed to really show and prove is a central millimeter-sized target with a very clear behavioral assay that really can provide a proof of concept that we can target deep brain structures in a way that is safe and effective. And that really made essential tremor the optimal initial application as a proof of concept to really demonstrate that this technology has legs, and then this technology can be used more widely. So what are the advantages then to the neurosurgeon of focused ultrasound lesioning? Well, the first is that we can harness the power of MR thermometry in real time, and we can get direct feedback of how hot the brain is actually getting. So every 3 seconds we get direct feedback, and in the course of a single sonication, which is a treatment session, we can see peak temperature both at the voxel and pixel level, just how hot we're getting, and then a dissipation of energy shortly after that. We directly visualize the target in real time. So when we target, in this case, the left VIM nucleus of the thalamus, in the case of tremor, we can see a lesion develop in real time in the MR scanner, and most patients leave the scanner with the lesion directly visualized. And of course, there's the fact that we can provide real-time clinical assessments. There's a real-time behavioral assay. In this case, the tremor can go away, and we can test the patient both from postural and kinetic perspectives to see these lesions have their effect. The added advantage is that we can actually sonicate at sublesional levels, so at temperatures where we're not causing a permanent lesion, and detect any adverse events, any untoward effects, and also effects on the tremor in order to allow us a kind of mapping of the thalamus so that we can know that we're in fact having the clinical effect that we're desiring, but without any of the side effects. So this is one of our patients, one of our first patients to undergo the procedure several years ago, with a very clear postural and action tremor here in his dominant right upper extremity, refractory to medications, as is typically the case in its more severe form. It's quite a disabling disease, of course. Here, this is his own MRI scan demonstrating a very discrete 6 to 7 millimeter lesion of the VIM thalamus on the immediate treatment day. And here he is immediately after the procedure with that tremor abolished. This for us has sort of changed the game for essential tremor and has lowered the threshold certainly for referral to surgical interventions, given that this has largely become an ambulatory procedure with patients discharged within 2 hours of their operation. So several years ago, together with Jeff Elias at UVA and 7 other sites across the world, we conducted a randomized trial of focused ultrasound thalamotomy, a 3-to-1 sham to active arm trial, where we established quite well and definitively the effectiveness and the safety profile of this procedure, and ultimately led to federal approval for this. Looking at the side effects, looking at some of the adverse events compared to deep brain stimulation, which is the most common alternative treatment for essential tremor, the side effect profile is quite favorable. The most common side effects are those related to the actual lesion. In the vast majority, these are mild. The most common are going to be sensory changes occurring in a mild form up to 20% of patients, as well as balance issues that can occur in up to 13% of patients in mild form, and in a smaller proportion of patients happening more significantly in moderate to severe. The vast majority do improve by 3 months, such that several months after the procedure, these side effects are largely dissipated in many patients. So just to give you a sense of how this has changed our practice, so at Sunnybrook, which is my institution at the University of Toronto, we first asked for research ethics approval in 2011 to perform the first case, and we treated our first patient in 2012. We, along with the UVA group, published our experiences in 2013 in the proof of concept trial, proof of concept studies. And then we spent several years doing the pivotal study, again, with Canadian, American sites and some groups in Japan and South Korea. And then that led to regulatory approval in the US and Canada in 2016. So that period of time, that 6 or 7 years from initial ethics submission to full regulatory approval, is about a third of the time it takes a typical device to go from idea ultimately to commercialization and approval. So that really reflects the dramatic sea change in terms of how we treat this disease and how effective this technology has become at spreading sort of a wider treatment options for tremor. So at our institution, we're quite a busy institution where we treat hundreds of patients. We've treated now close to 400 patients over the last several years. This is fully reimbursed, fully ministry funded. Typically, we don't treat bilaterally in the same setting. There's a very robust literature where we know that bilateral thalamotomy is unsafe in a single sitting. So we do stage our bilateral treatments and have recently shown that, in fact, a staged bilateral approach is safe and effective. And here, too, the FDA and Health Canada has provided approval for that. So really the success of generating lesions less invasively with ultrasound spurred us along and got us thinking, well, there are other conditions, of course, where making discrete lesions of the brain can be safe, can be effective, and there's a very robust history for it. And these include the non-motor circuit conditions, and specifically OCD and depression, where capsulotomy and cingulotomy have been around since the 50s and 60s and the stereotactic era, really taking hold in the 70s and 80s. And these are highly effective procedures, but nevertheless associated with side effects that, for many in the community are unacceptable, of course. But, there is a decades-long history of ablation and treatment-refractory mood and anxiety disorders. But typically, the lesions look like this: very large, very uncontrolled, associated with significant damage and swelling to medial structures here, accounting in many ways for some of the side effects that are known to be associated with these procedures. But now we have a technology that can generate lesions like this: very discrete, very controlled, thermometry driven, in this case what we call snowman lesions, bilateral double lesions in the anterior limb of the internal capsule, generating a capsulotomy lesion, very, very different from what you see with radiofrequency. So what do you do then with a technology that allows you this level of precision, this level of specificity? Well, we built a program around this. We treated our first patient in 2018. We're fortunate at Sunnybrook at our institution to have Canada's only residential OCD treatment facility. So we have a steady collaboration and partnership with our psychiatry colleagues, and we see quite a bit of patients with refractory OCD and depression. And when we looked at the data from the first 14 patients that have reached at least 6 months follow-up, we can see that on average, these patients have an illness duration of 20 years with response rates following focused ultrasound capsulotomy in the range of 50%. So this is very similar to what we see after open radiofrequency as well as deep brain stimulation for this condition, indicating that, in fact, we can use this much less invasive approach as a lesional ablative surgical strategy for patients with refractory OCD in this population. So again, average illness duration of 20 years with a very favorable treatment response rate. So we're very interested in this, and we've moved this forward. We've established one of the few multidisciplinary psychiatric neurosurgery clinics in Canada, staffed by a team of neurosurgeons, psychiatrists, and neuropsychologists, and have become a kind of provincial national resource where we provide a comprehensive eligibility assessment strategy for patients across the board and develop a kind of pipeline of care where focused ultrasound is one tool amongst the treatment continuum. And that's really how we view this tool, which is really just an additional therapeutic strategy and a broader comprehensive strategy to treat patients with refractory OCD in this case. Ultrasound, of course, not without its limitations. Several of them exist. Currently, they're the source of ongoing engineering solutions, but nevertheless, it's not for everybody. What we do know is that the skull matters for patients, specifically the skull density ratio, which is the ratio of cancellous to cortical bone. Just like everywhere, ultrasound does not travel very well through less dense material. So the less dense the skull, the more challenging it is for ultrasound to transgress the skull. So there are some patients for whom this procedure is just not possible. That try as we might, we try to raise the power of the ultrasound, we cannot generate ablative lesions. And this is particularly a challenge the further you get away from the geometric center of the brain, because you need to turn off several transducers in order to get to those regions of the brain. It's also a challenge for bilateral treatments. So with Tremor, we treat unilaterally, less of an issue than for a procedure like capsulotomy, where we know you need to make 2 lesions. You know that bilateral treatments is necessary for a treatment effect. And we are seeing situations where the skull density ratio is certainly dictating the size of the lesion on the contralateral side after you've treated one side. So this will have implications for ultimate lesion size, for the durability of the response, whether it's for tremor or for mood and anxiety. All of these are active areas of investigation and engineering, and I do think that it's only a matter of time before they're overcome. But these are issues currently that we're openly discussing with patients when we consent them, of course, and with all the companies that are manufacturing this technology. So pivoting now to therapeutic delivery, which, I often describe, lesional HIFU, high frequency ultrasound, as a very new tool that does something very established in neurosurgery, which is generating lesions. With therapeutic delivery, we're talking about a new tool that does something that doesn't exist yet in neurosurgery, which is helping enhance the delivery of potentially promising therapeutics to the brain. And here's where the blood-brain barrier really comes into play. So, of course, I don't have to tell this audience that the BBB is a major challenge for the delivery of therapeutics. Many different technologies over the last several decades have been developed to try to overcome that. So whether it's molecular mimicry approaches, chemotherapy impregnated catheters, microchips, convection-enhanced delivery, all of these approaches have been tried, but they're all associated with their respective advantages and disadvantages. But a way to transiently and safely overcome the barrier although it's long been sought, the currently available technology has been met with mixed results. So how does ultrasound potentially help? So here, again, we're using low frequency ultrasound. We're not using high frequency. And the reason is we pair ultrasound with injected microbubbles. So we inject patients with a commercially available microbubble formulation known as Definity, which is a very commonly used contrast agent in patients undergoing cardiac echo imaging. The microbubbles will circulate throughout the body, they'll get to the brain, and then we expose regions of the brain to low frequency ultrasound. There's no associated temperature rise, so there's not the same geographic, spatial limitations that you see with HIFU. The microbubbles will absorb the energy of the ultrasound, and they'll oscillate, as is shown schematically here. They'll oscillate 500,000 times a second, so very, very fast. And they will cause a physical pulling apart of the cells making up the blood-brain barrier. And they'll do that temporarily, so that whatever is circulating in the bloodstream, in this case the purple spheres, but it could be any therapeutics that you deliver, will have a transient window to go from the intravascular space to the extravascular space and target any pathology in the area. We know that the blood-brain barrier is open for less than 24 hours, and preclinical models suggest it's open for about 8 to 12 hours. So some of the first preclinical work was done at Sunnybrook at our institution, led by Kalervo Hinanen, who's one of the pioneers of focused ultrasound technology. And one of the first drugs to be delivered was Herceptin or trastuzumab. So the typical compound that can get across the blood-brain barrier is about 300 to 400 Daltons. Okay, the Herceptin or trastuzumab is 150,000 Daltons. So orders of magnitude larger than the typical compound that can gain access to the BBB. Herceptin, of course, known to us because very commonly prescribed chemotherapy for breast cancer. And most patients that have breast cancer die from untreated intracranial disease because it cannot get into the brain. So what this animal model showed, one of the first shots across the bow of the BBB drug delivery space, was that in fact you can use ultrasound, shown in the upper right here, with contrast enhancement. So gadolinium weighs about 1 kilodalton, so twice as big as something that can get across the BBB, and of course appears in areas where the BBB is already disrupted. So here you can show that in a mouse model, you can open the blood-brain barrier, you get a very focal opening with gadolinium delivery. And at the bottom right here in this graph, showing that the MRI intensity of gadolinium actually varies directly with the Herceptin concentration that was detected. Okay, so you can use gadolinium as a kind of proxy measure for BBB opening, and you can get a significant rise in Herceptin concentration in those regions of the brain. So we paired with our medical oncology colleagues to design the first trial of Herceptin delivery with focused ultrasound directly to the brain in patients in a phase 1 trial. So these patients were ones who will have progressive intracranial disease with very well-controlled systemic disease. So on the left, you can see a region, you can see a lesion, an intraaxial lesion in the region of the cerebellar peduncle on the right side, otherwise progressive disease. Here we target with focused ultrasound. This is not a heat map that you're seeing. This is an indirect measure of microbubble activity indicating blood-brain barrier opening. You can see increased contrast enhancement in the region of the tumor that was directly targeted, and that fluffy white extra BBB opening went away the next morning. So you can see that A and C look very similar, and indicating a closure of the perilesional blood-brain barrier around that tumor. What we did in this study is we wanted to actually visualize trastuzumab in the brain. So up until now, up until this study was done, we just assumed that when you open the blood-brain barrier, more chemotherapy was able to get in based on the preclinical work and based on the work that was done in very early stages. But what we did here is we worked together with the radiochemistry team at the University of Toronto, and we actually tagged trastuzumab with 111 indium so that we can visualize it on a SPECT scan. So here you see that very same patient on the left with their tumor. And the middle panel shows that when you inject patients with 111 indium before ultrasound and you image with a SPECT scan, you see trastuzumab basically pooling the venous sinuses and the cavernous sinuses and other areas of the brain, except the tumor itself. No trastuzumab is able to get in. Immediately after focused ultrasound, we took patients to the SPECT scanner, and you can see a significant rise of binding of 111 indium labeled trastuzumab within the tumor. So the first direct visualization, you can get this huge molecule, this monoclonal antibody, into the brain in significant amounts that ordinarily does not get in. So this has significant implications, we believe, for all drug delivery strategies across the board, and we're quite interested specifically in the pediatric space as well. Jim Rutka, who's a close partner and collaborator here at the University of Toronto, developed some work in preclinical models of diffuse intrinsic pontine glioma, or DIPG, showing that in animal models you can use focused ultrasound to enhance the delivery of doxorubicin, which is known to be effective but cannot get into the brain in sufficient amounts. So we designed a phase 1 trial, ultimately hoping to recruit 10 patients aged 5 to 18, and each patient will be treated 3 times in a dose-escalated fashion. This is the first adult pediatric collaboration of its kind. We're quite excited at its potential, and the first patient, in fact, was enrolled back in January. So how does this look like in that patient? So here on the leftmost panel, you can see the typical fat pons appearance of a non-enhancing DIPG. Here you can see a biopsy tract of this patient who underwent a biopsy previous to this. When I say that we are doing a dose-escalated fashion, by dose, we keep the doxorubicin dose constant, but the dose is the BBB tissue that is opened. The first treatment is 50% coverage of the pons, and here you can see very nicely only 50% of the pons on the left side was targeted, and you can see contrast enhancement very discreetly in that part of the brain. Patients ultimately recover because they come back a month later where we do 75% coverage and then ultimately 100% coverage, including previously biopsy area. 24 hours post, you can see the contrast enhancement gone. So transient, anatomically precise and spatially precise BBB opening with doxorubicin delivery for the first time in a human child. Just to show you the level of anatomic specificity, this is the treatment console here on the left. And when we open the blood-brain barrier, we do it in axial slices. And when you show the corresponding sagittal view that we're seeing here with the BBB opening, you can actually see the rows of BBB opening because you can see contrast enhancement in those same corresponding axial slices. So that just shows you the level of precision that we can achieve by opening the blood-brain barrier, and we can go virtually anywhere within that blue circle that you can see on this console on the left. No region of the brain is inaccessible to focused ultrasound with low frequency. One of the interesting parts of working in this field is it exposes us to diseases that maybe we wouldn't ordinarily be treating, specifically in the neurosurgical space. So we have a very strong interest in our group looking at the neurodegenerative diseases, specifically Alzheimer's and Parkinson's disease. As a functional neurosurgeon, of course, I see a lot of these patients, but it gives me an opportunity to work very closely with our neurology colleagues on potentially developing novel therapeutics in this space, recognizing that the blood-brain barrier may be an important obstacle for delivering potentially promising therapeutics. So we know from early preclinical data that focused ultrasound can be used to transiently open the BBB, deliver therapeutics to transgenic mouse models of Alzheimer's disease, and aid in the clearance of pathologic amyloid and tau. So we leveraged that and developed the first human trial of using BBB opening, again, in mild to moderate Alzheimer's disease. Here, we enrolled patients with known amyloid positivity. So here you can see amyloid developing specifically in an asymmetric pattern in this patient with most of the amyloid in the right frontal area. This being a phase 1 trial, we wanted to basically do the homologue of an allergy test in the brain, a very discrete patch of blood-brain barrier opening corresponding to amyloid positivity. And here you can see there's rectangular area of contrast enhancement that went away the next morning, indicating reversible BBB opening in this patient, which is, again, in a human population, the first time that amyloid positive tissue has been opened. Since then, we're in the midst of doing a phase 2 trial where we're targeting larger volumes in the brain in up to 10 brain regions that we know are implicated in Alzheimer's, specifically in the default mode network. In this study, we target bilateral cingulate, bilateral precuneus, and bilateral hippocampus. This is the first patient that was treated in this trial. We recognize, of course, that Alzheimer's disease is a brain-wide disease, but we also know that amyloid and tau deposition occurs in very systematic ways and in very stage-like fashion from early to more advanced stages. The rationale here is if you can intervene earlier in discrete regions of the brain where we know regions are amyloid and tau positive, you may be able to have an impact on the trajectory of the disease. So we published our experience of opening the blood-brain barrier in the first 9 patients of this trial. We did not see any worsening cognitive decline in follow-up. And there was very early, we don't want to hang too much on this, but very early suggestions that we saw significant amyloid reductions in targeted parahippocampal and inferior temporal structures. Can we potentially use this as a strategy to reduce amyloid? Remains to be seen, but nevertheless something we're quite interested in. I'll mention the work in Parkinson's disease just in a single slide here. We're very interested in seeing if we can deliver enzyme replacement therapy to a genetic form of Parkinson's disease called GBA-PD. This is a form of genetic PD that we know patients are lacking a specific enzyme called glucocerebrosidase. It's the biggest genetic link to Parkinson's disease. So here we have the ability to deliver something that's missing in these patients, specifically the enzyme. So here in the first phase 1 trial, in close collaboration with our neurology colleagues, we opened unilateral putaminal blood-brain barrier opening. And here you can see the BBB being opened on the right side, and you can see contrast enhancement in that area in a very precise anatomically targeted procedure. What was neat about this study is we actually performed glucose PET. So we did FDG PET in these patients pre and post intervention. And here you can see at baseline putaminal hypermetabolism, which is a radiographic hallmark in patients with Parkinson's. The further along they get in their disease, the more hypermetabolic and hyperactive their putamen becomes. And what you can see here, we only treat on the right side 1 month after the intervention. When we do repeat PET scans, you see a significant reversal of that. You see a hypometabolism in the targeted putamen that you don't see on the untreated side. You'll recall that the blood-brain barrier is long closed by this point. This is a month after the last treatment. So this indicates to us, are we seeing a biologic effect? Are we seeing a more long-lasting effect that could potentially ameliorate maybe some of the radiographic and neuropathologic hallmarks of the disease? So the final future direction really deals with personalized approaches, and this, in many ways, is some of the most exciting areas of this field. This has to do with liquid biopsy strategies. We talk a lot about drug delivery and getting these large compounds into the brain. But of course, the blood-brain barrier is a bi-directional road. We may very well be able to get things out of the brain as well. So many of us are thinking about, well, can you use transient opening of the blood-brain barrier as a way to enrich peripheral biomarkers for key markers of disease in the brain? And of course, it has implications for lesions like this, where the differential diagnosis is either very difficult to get to malignant tumor or a highly treatable lesion that's responsive to chemotherapy. So the question becomes, can you use ultrasound BBB opening as a way to detect peripheral biomarkers, obviating the need one day for open neurosurgical approaches? And the early suggestions may be that yes, we may be able to. So this is work that was done by Dr. Ying Meng, who's a neurosurgery fellow currently and a former PhD student in the lab. And what she showed is that when we collect plasma immediately before and immediately after focused ultrasound, we see significant rise in cell-free DNA that was not apparent at baseline. And in fact, when you take plasma from different patient populations and look at a methylation profiling analysis, you may start to differentiate different disease and different patient populations by just looking at those markers themselves. So can we use ultrasound as a way to make a blood-based diagnosis? That is one of the questions that we're looking at now. We're part of a pivotal trial that's being run at multiple sites in the US and in Canada, looking at liquid biopsy in patients with presumed high-grade glioma, where we treat patients with ultrasound preoperatively, take them to surgery, sample the tissue, and ultimately make the comparison with tumor obtained at surgery and the biomarkers to see if we can make that correlation. So the first patient that we enrolled in that study was in November, and that study is currently ongoing. So what's been our experience so far? So we've treated 500 times at least at Sunnybrook across multiple indications. What are some of our lessons learned? Generally speaking, focused ultrasound is well tolerated. It's done as a same-day ambulatory procedure. We've not encountered any serious adverse events related to blood-brain barrier opening. We can target virtually any brain region, large brain regions, multi-target brain regions, including an eloquent cortex, motor, sensory, brainstem, and periventricular. We can do it technically, feasibly, and safe. We strongly believe in a kind of progress and parallel approach where we have a very core team that runs a lot of the clinical trials, but we're very fortunate that we have domain experts across the neurodegenerative space and the oncologic space and the mental health space to allow us to move a lot of these trials forward. So as a result, if we were to build a program, what we would invest in are certainly strategic partnerships that, again, we're very privileged to work with industry partners, hospital and research institute partners. For those of you, of course, who do clinical trials, you know that the vast majority of the work, greater than 80–90%, is going to be regulatory and it's going to be coordination. So we work very closely with Health Canada, with our FDA partners in many of our trials, and investing in that is just a huge return if we're able to focus on that. And that's where the team comes in. You're hearing me talk, but we have a tremendous team that I've great privilege to work with each day at Sunnybrook. So the technology is evolving in real time. This is what our technology currently looks like, and that technology that we're using. This is manufactured by Insight Tech. This is the Exablate machine that we use in 2023. It's a stereotactic procedure. It uses cooled, degassed water and a 3T research MR in real time and over 1,000 transducers. It's evolving though. Next year and beyond, we're starting to use frameless procedures. We're not shaving the head or giving patients haircuts anymore. Ultimately, we're quadrupling the number of transducers. There are strong ambitions to take this outside of the MRI environment and potentially make this a portable procedure. So every aspect, the hardware and the software, is evolving rapidly, but it remains a very precise and image-guided procedure to a wide range of brain pathology. So we've come a very long way, I would say, from the 4 transducer model to where we are today. So where are we going in terms of future directions? So certainly expanding indications, making anatomically, spatially, and temporally precise lesions for procedures for indications like essential tremor, like OCD, like chronic pain, and down the road for things like epilepsy, where we're really relying on precise precision strike lesions. We have the potential to replace open neurosurgical approaches. On the therapeutic delivery side, certainly it's going to be combinatorial combination therapies for cancer and neurodegenerative disease. It won't just be one drug. We don't have to just deliver one drug. We can deliver multiple drugs, but portable, shorter treatments, making this an ambulatory day procedure kind of apparatus and setup is the goal. And a personalized approach. So you can envisage a situation where patients are undergoing a screening MRI scan for a certain indication and making an early diagnosis of radiologic findings and monitoring disease as well. Can we differentiate radiation necrosis versus tumor recurrence, et cetera? Those kinds of decisions are really in the sweet spot for a technology like focused ultrasound and liquid biopsy. So it's one of the few tools that I say, has a diagnostic, treatment, and preventive angle to it. So quite robust, and I think the future is quite bright for it. So with that, I just want to thank the tremendous team that, again, I have the great privilege of working with at Sunnybrook and the University of Toronto. Kalervo Hinanen, who's one of the pioneers in focused ultrasound, all of our research managers, our students, and our industry partners. So thanks very much. Happy to take any questions.
Yeah, hi, it's Justin Singer. I have a question. I know you said, and you showed some cases, especially with the pediatric pontine gliomas. Is there any limitation just on time course of the procedure or size of lesion that's safe for right now? Or how do you gauge that, and what limitations are there for larger lesions right now?
Great question. The main limitation is time, and it's so the DIPG treatments are all done under general anesthetic. So there's not the same time restraint as there is if somebody's awake under conscious sedation. But we can target up to 70 to 80 cc volume tumors, and we've done that for some of our recurrent GBM patients. So no real restrictions from a technical perspective. It's really just a feasibility, patient tolerability perspective.
Smaller lesions in adult patient populations, are you doing that under general anesthesia as well, or is that moderate?
The only procedures we use a GA for are the pediatric indications.
Yeah, hold on for one more question.
Really nice talk, Nir. Kostas Hadjipanidis. What do you think of the sonodynamic therapy studies going on right now?
Yeah, I mean, I'm excited by them. I think they're terrific. I mean, I think that it's a small community, so we're all cheering each other on and seeing the kind of work that's possible. I think that it's an incredibly versatile tool and technology, and I think that, as with many things, it's going to be a combination approach. It's not going to be, FUS alone for recurrent GBM or FUS alone for any of these big complex diseases like PD or AD. So I think that I'm excited by the work that's coming out of sonodynamic therapy, and I think that it has a lot of potential for sure.
Great. Well, thank you so much for your talk. Sorry you couldn't be here with us, and I apologize on behalf of United Airlines.
Thanks very much. Thank you. Thank you.